kind of like you said, I'm going to talk about is endograft repair of infrarenal abdominal aortic aneurysm and descending thoracic aortic aneurysm. Is that right for everyone? Just briefly, as has been touched on before, we look to repair infrarenal abdominal aortic aneurysms when anywhere between 5 and 5.5 centimeters. It's really greater than 5.5 centimeters that the risk of rupture outweighs the morbidity and mortality of repair. With EVAR, kind of indications have kind of slid down a little bit, so anything really above 5, we're kind of looking to possibly repair. For thoracic aortic aneurysms, the aorta is a little bigger. We go to about 6 centimeters there. Typically, before we repair anyone, we like to have a CT angiogram to really define the anatomy, to really see where the aneurysm is and how it's best to repair it. There's really 3 main treatments: endovascular, open, and medical management. Unfortunately, there has been no drug or pill that has been shown to reliably inhibit the growth of these aneurysms. So for now, to prevent prevent rupture, we're really left with either surgical therapy, either endovascular or open. So open repair, obviously, has been around for 40 years probably. Our goal there is to replace the artery, typically with either a Dacron graft or a PTFE graft. We like to sew these below the renal arteries and clamp below the renal arteries, hopefully. Usually it's through a midline incision or a retroperitoneal incision. Typically, these patients are staying in the hospital anywhere from 5 to 7 days. Probably about 25 to 30% of them will need some sort of subacute care. And as was touched on before, the mortality for open repair electively is anywhere from 3 to 5%. Endovascular repair, a little bit of different strategy here. We're actually relining the artery from the inside, so we don't actually get rid of the aneurysm, it's still there. We are essentially sealing it off. So we need some healthy tissue, hopefully below the renal arteries, about 1 centimeter, and some healthy tissue in the iliac for that graft to seal in. And then we hope that the artery will kind of shrink, or the aneurysm will shrink around that. Obviously, it has some anatomic limitations. You need to have a minimum diameter of your artery of anywhere from 5.5 to 6.5 millimeters in your iliacs to actually deliver these devices. Luckily, though, we're able to do that usually with either groin punctures or very small groin incisions as opposed to a full-on laparotomy. These patients are staying in the hospital probably, for us, on average of 1 to 2 days. Some people are actually trying to send them home the same day now. And I'd say it's pretty much accepted that there's a significantly lower morbidity and mortality. The 30-day mortality for EVAR is approaching 0.5%. One of the kind of the big topics on EVAR, one of the knocks against it, if you will, is that since you're not actually removing the aneurysm, there's more secondary interventions associated with it. And one of them that we're most concerned with is endo leaks. And Bart kind of touched on this a little bit, but there's really 4 types of endo leaks. Type 1 is where you see a leak around the main seal zones. And those are usually seen during the initial operation, and we usually are able to repair those immediately. Type 2 is the one that is very persistent and the one we've spent a lot of time trying to deal with, and that's usually back bleeding into the sac from lumbar arteries or the inferior mesenteric artery. Those are arteries that we just cover, whereas in open repair, they were actually ligated or sewn shut. So the endo leak rate approaches about 25% of patients undergoing endovascular therapy. In the large majority, those are type 2, because like we said, type 1 we usually fix immediately. And looking at, this is actually data from one of the endograft, from a Gore endograft. About 3% require reintervention at 1 year, and about 94% of aneurysms actually decrease in size or are the same size at the same year, and that's actually what we're looking for. This is just a quick sample case. So typically we try to seal below the renal arteries. Most endografts that we use now are requiring about 1 centimeter of healthy tissue. So we're able then to basically deliver the graft through the iliac, through the femoral artery, right up to that artery, and then essentially deploy it. You can see it becomes sheathed. Nitinol basically reaches its maximum tensile strength at body temperature, and that's how it's able to be kind of constrained at room air, but at body temperature becomes much stronger. A lot of these grafts are configured so that they have a little gate where we basically access the second leg to kind of form a pants-like looking structure that seals below the renal arteries and in the iliacs and essentially excludes the aneurysm. So trying to figure out if one is better than the other, trying to find some long-term data. This is a study done in 2011 looking at 45,000 Medicare beneficiaries that underwent elective open repair and endovascular repair from 2001 and 2004. Obviously, that was a while ago, but we needed that to get our 6-year follow-up. So one important slide to note is that for EVAR, what they found is that, as I mentioned, the mortality at 30 days is lower. However, if you take that out to 6 years, the lines do cross, and that open patients that have had an open repair actually have a higher survival than EVAR. It's small, but it is a significant number. And actually, those you can see with re-intervention actually had a much lower survival. And this is from the same study. And this is looking at re-intervention rate for EVAR versus open, and this is a rate per 100 persons per year. So all comers, EVAR, the average was about 7.5 per 100 versus 7 for open. In this study, that was statistically significant, and all that carried with it a 90-day mortality for both open and EVAR. Obviously, people that were older had more interventions for both EVAR and open. Kind of most concerning was that EVAR actually had a higher rate of re-interventions for rupture. So even that's 0.5 per 100, but you can see that when that happened, the 30 mortality jumped up to 30%. Some people say that is because when you have an EVAR, follow-up is critical. You really have to surveil these grafts frequently. If you have somebody that's lost to follow-up, you'll see them 3 years later with a rupture. Looking at cost effectiveness, obviously that's a hot topic these days. This study came out in 2012. This was looking at VA centers. And basically what they found that after 2 years, the survival, quality of life, and costs were not significantly different. I will point out that on the last curve, it is about 2 years when the lines for survival cross. But they did find that the costs were significant, and that's still going back, treating for endo leaks in EVARs and that sort of thing. This is a slide basically looking at EVAR for rupture. Blue is open repair, red is EVAR repair, and kind of like what Bart pointed out to us, endovascular repair of ruptured aortic aneurysms has rapidly progressed, and that is because you'll see that the 30-day mortality for EVAR is now, for rupture, is down to 25%, where it's up to 44% for open. And as we said before, if you rupture at home, your mortality is more like 90%. It's about 44% in the hospital. So. And they found, and this was from the group in Albany, very busy vascular practice, the survival advantage was maintained for 5 years. I'll kind of summarize this at the end. We're going to talk a little bit about thoracic aortic aneurysms. Bart touched on this a lot, but open thoracic aortic aneurysm repair is a very stressful surgery for the body, probably one of the most stressful surgeries that the body can undergo. Requires a clamp just distal to the subclavian, which can be stressful for the heart. Same principle, we're replacing the aneurysm. Obviously, these patients are getting large thoracic incisions requiring chest tubes. Their length of stay is anywhere from 9 to 10 days. Prolonged ICU stay, probably a little bit of higher percentage end up in the subacute facility. One of the things about open thoracic repair that's different from open infrarenal abdominal aortic aneurysm repair is spinal cord ischemia and the risk of paraplegia, which is a defined rate. So for open repair, you're looking anywhere from 6 to 16%, which is pretty significant when most of these people are walking coming in. At high volume centers, that number goes down, but still it's pretty significant. So for thoracic aortic repair, Bart touched on this a little bit in his talk, but basically this is a tube graft, a little bit different from the infrarenal, which is a bifurcated device. These are much larger devices. Usually you need an iliac artery size of about 8 millimeters to deliver it. Can still do it percutaneously through groin punctures. Sometimes you'll need groin incisions. There is still a rate of spinal cord ischemia. It is definitely less than in the open group, but it is present. ICU stay may be necessary depending on your hospital and how many of these you're doing. Endo leaks and re-intervention is still a problem, just as Bart was talking to us about. It is kind of similar to abdominal aortic aneurysms. This is just kind of a sample case. This is a large descending thoracic aortic aneurysm. In these cases, we like to have a healthy section of tissue, at least 1 to 2 centimeters, that's just distal to the subclavian. It's kind of marked there. And then hopefully there's some healthy aorta above the celiac artery, so we'll try to seal there. And this is a Gore device. Basically, you can see it's constrained. It did make it through this tortuous anatomy. This actually took about 2 pieces, but eventually the aneurysm was sealed off. So trying to decide which one is better, open or TEVAR. This was a study 2013 out of Massachusetts General in Boston, and they did a large retrospective review looking at 3,500 open versus 35 TEVAR. This study was actually designed to basically decide if a high-volume center had less morbidity and mortality than low-volume centers and teaching hospitals but it did allow us to gather a lot of data, a lot of follow-up data on open versus EVAR. And basically what they found, average 30-day mortality at all the different hospitals they looked at, 12% for open versus about 5% for TEVAR. 30-day complication, 50% for open, 30% for TEVAR. Obviously those numbers are pretty high, but these are pretty major surgical cases. What they found that was significant was that for open repair, you should definitely have that done at a high volume center. They do have less morbidity, less mortality, less spinal cord ischemia. However, for TEVAR, they did not find those differences. So TEVAR was able to be done at smaller hospitals, basically with the same rates of complications as the high volume centers. They also found that 5-year survival was similar, and the reintervention rates were similar or less for TEVAR. This is just an interesting slide, I think, taken from this article to show you how popular TEVAR has become. Basically, looking at the total number of cases done in 2004 for all open-end EVAR was 1,300. By 2007, the rate had increased to 2,000, and that's mostly because TEVAR, 351 done in 2004, 1,200 done in 2007. So basically, I think a lot of people are finding patients they would not have operated on in the first place, and they are doing an endovascular repair on these patients. This is actually a study that Bart was a part of, and it was in his talk. But you can see that this is, as he said, open repair, blue, significantly down. This is for rupture. TEVAR way up. So basically, rupture is now the essentially preferred choice for ruptured descending thoracic aortic aneurysms. And they do it with much less 30-day mortality than, or in morbidity than open. So briefly, is endograft repair of abdominal aortic aneurysm and thoracic aortic aneurysm right for everyone? This is kind of a pro and con list. I would say no. It can't be. Our devices can't reach everyone. Although with the way the technology advances, as Paul will talk about in his next talk, eventually we will be probably able to treat everyone with endovascular therapy. But for now, we have vessel size is a problem, angulation is a problem, whether or not they're paravisceral, paracervical. Some of these patients we just cannot deliver the devices there. Also, if you have someone that tells you they're never going to follow up again, they probably should not get an endograft. Endo leaks and reintervention is an issue. These patients do probably have more procedures than someone that's going to go into open repair. So I think, and the long-term survival, especially in infrarenal aneurysms, is longer. So I think if you do have someone that's young, has minimal comorbidities, has a long life expectancy, I think you should probably at least offer them an open repair. They may not take it when I describe the benefits of EVAR, but I do think they should be offered that. So is it right for everyone? I would say absolutely yes for TEVAR. I think far and away, TEVAR wins the argument versus open repair. For infrarenal abdominal aortic repair, I think that's also very attractive. Morbidity and mortality is significantly decreased, shorter hospital stays. We're basically doing incisionless surgery at this point. So far, the costs are looking to be equivalent. It's better for rupture. And as I said, for TAA, there's no incidence of, or the incidence of spinal cord paraplegia or spinal cord ischemia and paraplegia is lower. So. Thank you very much. That is my talk. And I think Dr. Gani is next.